1559, going to 1559. No, you start. Okay, hello, good evening and welcome. My name is Joseph Gar, ABU Pharmacy Alumni in 1984. On behalf of ABU Alumni UK and Ireland, I extend a very special welcome to you all. If you are joining our function for the first time, then you have a very warm welcome. If you are an ABU graduate and reside in the UK or Ireland, please consider visiting our website, ABUAlumni.uk, and consider becoming a member. I want to, at this very point, acknowledge the presence of the Vice Chancellor, Ahmadu Bello University Zaria, Professor Kabiru Bala, and also the President, ABU Alumni Association Worldwide, Architect Sani. Thank you for joining us. The title of today's lecture is The Burden of Prostate Cancer in Black Africans. World Health Organization ranks prostate cancer as the 4th commonest cancer in the world. If it is common, then I think there's a need for us to be aware of steps we can take to minimize the risk. We also tend to have prostate cancer patients presenting at very late stage. So it's important for us to be aware of all the early signs and symptoms, and also to be fully aware of all the necessary tests and screening that we can undertake. Thirdly, Black Africans in particular tend to present the disease in a very aggressive manner, or the disease might present in a very aggressive form. So there's a need for us to be aware of all the treatment options, surgical and non-surgical. Such information could be life-saving. These factors, among with other factors we're going to look at today, makes today's lecture the burden of prostate cancer in Black Africans a public health necessity, and if I may add, a scientific imperative. I'm going to stop at this point, and I will invite the chairman, ABUAlumni, UK and Ireland, and the Vice President, International Branches, Dr. Ibrahim Hassan, for his keynote address. Dr. Hassan.
Thank you very much, Joe, for your speech. Yeah. Fellow alumni, Vice Chancellor of AB University, Professor Kabiru Bala, President, ABUAlumni Worldwide, Architect Ibrahim Sani Halil, ladies and gentlemen, it's my pleasure to welcome you to this lecture on prostate cancer. Now, this lecture will be delivered by 3 distinguished urologists, all of whom I'm proud to say are all ABU alumni. Hear more about them later. Now, Joseph has told you why prostate, the 4th commonest in the world. But even more important, the commonest among Black men, wherever Black men are, is by far the most common cancer. So, very important reason why we thought this would be of interest to everybody. Now, a few words about the association. Ours is a young branch inaugurated in October 2018. And I'm glad to say we actually hit the ground running, because after the inauguration in 2018, we had our first AGM in Stockport in July 2019. And we actually plan to have a lecture in London in April 2020. Unfortunately, the lecture had to be cancelled because of COVID. Now, following this, we had a period of inactivity, hoping that COVID will go away, and we continue. Sorry? hoping that COVID will go. Unfortunately, we realized COVID was not planning to go anywhere soon, so we had to shift online. And we had our first Zoom lecture on the 19th of September, which was on globalization, COVID-19, and implication for Nigeria, delivered by Professor Rajneesh Narula, another distinguished alumni, or rather a singular alumnus. Now, the success of that event gave us, and also the realization that COVID is not about to go away anytime soon. We realize that we have to shift our activities online for the foreseeable future. And that is why this lecture has been planned today. And there in the near future, other activities like our AGM will also be taking place online. Now, just a quick mention of 3 recent changes that are of significance. The first of the 3 changes is Professor Ahmed Mora, who was the president at the time of our inauguration, has completed his tenure of office on the 27th of February, just last month. Now, I want to acknowledge the fact that it was Ahmed who single-mindedly conceived the idea of forming international branches, and he approached me to discuss the idea, and with his support, encouragement, and perseverance, this dream of his became a reality. And I would like to acknowledge his contribution, which were pivotal to the success of the inauguration. And even after the inauguration, he continued to give us support during the killing period. So we thank you very much on behalf of myself and the entire association. A big thank to Ahmed Mora. Now, the second change, which follow on for the first one, is that when Ahmed stood down, we now have a new president, architect Dr. Ibrahim Sani Halil, who is our new president, who took over on the 27th of February. Mr. President, we congratulate you on your victory. We pledge our loyalty to you and we wish you a very successful tenure of office. And the last, but by no means the least, is on the 20th, in January 2020, Professor Kabir Bala, popularly known as Malam, became the Vice Chancellor of our great university. Professor Bala, we congratulate you on your victory. We wish you a very successful tenure of office. And we thank you very much for honoring our invitation to be with us today. I believe you're going to speak to us later today, telling us about your plan for the university. As the branch chairman, I like to lead by example. I've been allocated 5 minutes to speak, and I'm making sure that I confine my speech within the 5 minutes that I've been allocated. And I please request other speakers to try and do the same so that we run on schedule. Finally, can I once more say thank you all very much for honoring our invitation. I hope you have a very productive session. And I hand you over now to Dr. Joseph Gar, who is the moderator for the day. Thank you very much.
Thank you very much, Mr. Chairman. Well, you actually still have about 2 minutes to go if you want to take advantage. but thank you very much.
It's just to tell those who have 10 minutes, maybe they might use 8 minutes and allow time for questions.
Thank you very much.
Thank you.
Right. The burden of prostate cancer in Black Africans. This multidisciplinary lecture is divided into 3 segments, with all the segments will be presented by distinguished ABU alumni, with question and answer at the end. The first segment is prostate cancer, introduction, epidemiology, genetics, screening, and diagnostic by Dr. Sani Aminu. Dr. Sani Aminu, 1988 ABU medical graduate, is a consultant urological surgeon and a director of Urodol Services UK Limited, with postgraduate training in Nigeria and in the UK, leading to the fellowship of the Royal College of Surgeons. Dr. Sani Aminu has subspecialist interest in prostate cancer. He has a number of publications in peer-reviewed journals and a number of innovations, which include the use of colored Doppler in preventing bleeding during prostate biopsy. Dr. Sani Aminu currently has 3 patents under active consideration. The second segment will be the surgical treatment options. And this will be presented by Dr. Baba Malam Gana. Dr. Gana is a seasoned consultant urological surgeon. He's based in Wales, qualified from ABU Medical School in 1983, undertook postgraduate training in Nigeria and in the UK. Dr. Gana, a fellow at the Royal College of Surgeons, is a professor of urology at Yobe State University Teaching Hospital, a visiting professor to a number of universities in Sudan. Dr. Gana, I'm going to use his full name, Dr. Baba Malam Gana, a recipient of international awards with extensive publications in reputable journals. The third and the final session will be taken by Dr. Falalu Danwata, and this session is titled Non-Surgical Treatment Options. Dr. Falalu Danwata, an ABU medical graduate, 1990, is a clinical oncologist, a specialist in the treatment of cancers of various organs, including genitourinary cancers, those affecting kidney, bladder, and prostate. Dr. Danwata is a founding member and a trustee of a number of charities, including West African Health Development Trust. He's also a member of the Chatham House, London. I'm going to hand you over to Dr. Sani Aminu to set the ball rolling. Dr. Aminu.
Good afternoon, fellow alumni. And thank you very much, ABUAlumni UK, for giving us the privilege to talk on the burden of prostate cancer in Black Africans. I also welcome our colleagues and friends from Nigeria. I don't have any disclosures to make. So with the introduction, I start with the anatomy of the prostate gland, but this will be dealt extensively with my co-speakers. First of all, the prostate is this green elliptical organ you can see in the center of the pelvis, surrounded by important structures like the bowel, the rectum, as well as the bladder, and at the lower end, toward the apex, by a very important strong muscle called the sphincter, which prevents us from leaking urine. On its sides are the erectogenic nerves that go to the penis to mediate erection. Physiologically, the prostate is essentially a sexual organ that secretes semen, through which the spermatozoa swim to the womb. The anatomy makes it complex. The biology and genetics of prostate cancer are also very complex, and this makes diagnostics and treatment challenging. However, technology and science has made matters easy through robots, endoscopes, newer pharmaceuticals, new genetic diagnostics and treatments. Okay. Okay, all this combined together when it comes to an African, it is also a great burden on us Africans. Judging from the incidence. If we look at this slide, which has the Globacon statistics on prostate cancer incidence in 2020, it shows that prostate cancer is the commonest cancer in many countries, including Nigeria, West Africa, Caribbean, USA, and Europe. If you see in Nigeria in particular, it is the commonest cancer, not only the commonest cancer in men, it constitutes about almost 30% of all cancers in men. In the Caribbean, it's 35.8. If you see, I put a star on the incidence in USA. If you profile the statistics, you find that there's gross disparity between Blacks and other races like Caucasians, Hispanics, and Asians. In Black Africans, it constitutes up to 37%. Now, coming back to the UK here, the process study done in London a decade ago showed that the incidence is about 166 per 100,000 in Blacks, compared to 56.4 per 100,000 in whites. And the relative risk between Blacks and whites is around 3. And if you see the charts here of the relative risk, is about, in fact, it's about 3.19 between comparing Black Caribbean men and white men. And 2.87 Black African men compared to whites. However, there is no significant risk in the relative risk between Black African men and Black Afro-Caribbeans. Then factors in the etiology of prostate cancer in Black men. Race and genes, very important. In general, 9 to 10% of prostate cancers have some genetic etiology. And African ancestry-specific genes were found during the genomic wall association studies, wide association study. And recently, other genes are found. And one of our alumni, I think, was involved in that research, Professor Abdul Gadri. That is the ZFHX3 and ETV3. There are also African ancestry-specific genes that confer unfavorable prognosis in prostate cancer in Blacks, like the TP53 and MYC, which can cause high-grade, which are associated with both high-grade and also metastatic cancer, respectively. In all races, as we know, the BRCA2 gene mutation confers aggressive prostate cancer. And there are others like BRCA1 and ATM. Family history, a situation where genes are not found, but we have maybe family members or clusters of families having prostate cancer, then we refer it as familial. But once the genes are found, then we say genetic, we refer it to genetics. If one sibling has prostate cancer, the relative risk of another one is 1.8, another sibling. If a father and a sibling has prostate cancer, relative risk is 5.5 to the other to a next sibling. If 2 siblings have prostate cancer, then it goes exponentially further to 7.7. So quite very important. Environmental factors are also known to influence prostate cancer. This includes diet, whether a person is sedentary, living or doing exercises, alcohol, smoking, hydrocarbons, radiation exposure. Hormonal factors also involved one way or the other from molecular biology studies, and also phenotypes. Okay. Why the high mortality in Black men? Race and genes, as above, are very important. Then socioeconomic factors, racial inequalities, especially in America, access to health, access to education, health insurance, etc., can make matters worse or can improve matters depending upon the situation. But in Blacks, as we know, racial inequalities have contributed to their mortality as well. Then we have already mentioned diet, radiation, chemicals, and alcohol. Cultural factors are very important. The health-seeking behavior of people, their taboos and myths can affect their access to health and can have a bearing on presentation and mortality. In 2014, we attended Global Congress on Prostate Cancer in Black people in Jamaica. And we were made aware that health education projects were taken specifically to influence Black men to accept digital rectal examination, which they take. They have very strong views against it because of their culture and religious ideas. Even in Africa, there are a lot of taboos and myths related to anything, any intervention or operation that involves the genitalia. This is just a chart to summarize what we have said. Now we go to screening for prostate cancer. As you can see, I did not put any slide specifically on prevention because I think the screening is the most important preventive measure against mortality. There are a lot of contradictory research done on preventive measures like diet and other things, but most of them are contradictory. One will show this advantage and another one will show that there's a big disadvantage, just like the selenium trial. So that's why, but in general, it is good for people in prostate cancer prevention, health education. It's good to advise people to stick to good living style in terms of diet, exercise, and the rest. Although importantly, there's one food product that that is found to have maybe some preventive measures against prostate cancer, but even that has been, contradicted. That is lycopene containing fruits and vegetables like tomatoes. But since it cannot harm, then why can't we just continue eating it or eat more? Okay, the European Organization for Research and Training in Cancer study revealed screening could reduce prostate cancer mortality, but it also advised us to avoid overdiagnosis and overtreatment to reduce harm from both. On balance, population screening is not recommended by the EORTC. Targeted screening is recommended for people above 50 years and for Black men and those with family history in particular from age of 45. And for those with abnormal genes, prostate cancer causing genes from the age of 40 even. Opportunistic screening is what we routinely do, but it has not had any significant impact on mortality. And to buttress the importance of screening, there's another study in America, the PLCO trial. PLCO study is a bit not accepted by people worldwide generally. Even in America, there's a lot of controversies on it. It discouraged screening. And when they discouraged screening, the incidence of mortality in prostate cancer increased. And I think they are going to, they have reversed, or they are going to reverse their previous plan. Okay. So we now go to, diagnostics. So diagnostics starts with clinical presentation. Patients that are well informed sometimes comes to their family physician asking for screening. They are usually asymptomatic, and we do take their history as normal, and then do rectal examination, and then blood tests, and then have discussions based on the findings. But most of the time, we do what we call the opportunistic screening. That's for people who just come with some symptoms, and then we go ahead and do the normal process of taking history, focus examination, and then we do discussions. The presentation of prostate cancer is usually subtle and non-specific, because it's the same presentation with, as we know, with benign conditions of the prostate or even the bladder. So more importantly, after history and examination, including digital examination from the back passage to feel the prostate, one of the most important things is discussions on the findings. And then tests, we discuss tests, further tests with patient, and what to expect, then advantages versus disadvantages, or harm versus benefits. We give people leaflets to read, especially if we have to go, if the patient needs to undergo further investigations. Then some patients need more information, and we sometimes refer them to the risk calculation websites, like the EORTC risk calculator, like the one that I've shown here. So we have already mentioned screening tests like PSA and DRE. If there's a suspicion, although sometimes one test is not enough, we need to repeat the test after 4 weeks, as you know. If either the PSA or the digital rectal examination is abnormal, then we ask the patients to have MRI. MRI has helped us a lot to diagnose properly, and also to avoid unnecessary biopsies and its related disadvantages. After that, if the MRI, all the three shows abnormality, or at least 2, then the patient will have tissue biopsy. There are 2 types of biopsies, but the second one, the transperineal, is the one that is currently done most of the time. The advantage is that it helps to reduce infection as a complication. So apart from the tissue biopsies, which is confirmatory, because we send it to the pathology lab and it confirms or refutes about prostate cancer. Apart from that, we have the liquid biopsy, which whereby we check the urine or blood for circulating tumor DNA or circulating tumor cells or things like exomes, and check their DNA and check the molecules there, and for prostate cancer signs. Other diagnostic checks are what we call staging tests. Just to say that, going back to this liquid biopsies again, it can help during diagnosis, monitoring, as well as surveillance, and choosing a treatment modality. Especially, I believe Dr. Falalu will talk to us a lot about it. It's important with for the oncologist. Then challenges of prostate cancer screening in Nigeria. There's limited knowledge of prostate cancer in the wider population. Although I believe elites know about prostate cancer, but in the wider population is a bit limited. There's also limited basic diagnostics like ultrasound. We need cost-effective ones. Late presentation from the above meant few suitable for operative treatment. Radiotherapy facilities and specialists are few for this very large population of 200 million. Few dedicated cancer centers for radiotherapy. Then priorities towards prostate cancer screening in Nigeria. We need expert committees. We need expert committees on groups of diseases like cancer and others. We need to establish subcommittees for prostate cancer and urological cancers. This then goes on to recommend training standards, research, guidelines, and pathways. There's need to establish cancer centers for groups of 3 to 4 states, depending upon their size. We then need to determine, they then need to determine based on all this, the best screening protocol. But this is still while health education, opportunistic and targeted screening is still going on. In conclusion, the prostate is a complex organ. The prostate cancer biology and genetics are also complex, making diagnosis and treatment challenging, but science and technology has made matters much easier for us. There's need for health education on prostate cancer in institutions and communities, as well as the organization of cancer services, so that we do good research to choose the best screening protocol. Thank you very much.
Thank you so much, Dr. Sani Aminu.
Thank you very much.
We have questions, but I think we deal with the questions at the end of the sessions, if that is okay.
Okay.
Thank you very much for very lucid presentation. I will now call upon Dr. Gana for the surgical treatment options. Dr. Gana.
Thank you very much indeed, my fellow alumni, and thank you very much for the invitation for the ABUAlumni UK&Ireland. It is my singular honor and privilege to thank you for this invitation, and I'd like to acknowledge the respectful Vice Chancellor, Professor Kabiru Bala, and also the worldwide President of the ABUAlumni. I'd like to share with you prostate cancer as we see it from the surgical perspective. And this dovetails to my colleague and friend Sani Aminu's presentation, which has covered most of the issues that as we see them in our clinics. I just want to recap some of the information so that it will be very clear and crystal in the minds of our colleagues, and especially women who unfortunately have this, they also do suffer from their husband suffering from prostate cancer. They too also share a lot of the burden. Now, the prostate grows in size as one gets older, and this can result in symptoms which are technically referred to as the lower urinary tract symptoms. For short, we call them LUTs. And these symptoms can either be due to prostate cancer or due to benign enlargement of the prostate. I'm emphasizing on this because I've seen on the chart one of the colleagues was asking about this issue. Now, the bladder itself is meant for function of storing urine for 23 hours and 55 minutes or so, in between which then, if you have any need or desire to pass urine, then you can then go to the toilet.
Sorry,
Now,
my apologies, Dr. Gana, I'm sorry to intervene.
Yes.
There's I think your speaker, I don't know whether you can move closer to the speaker. There's a bit of echo, so we can't hear you very clearly.
To where?
I don't know if you can move a bit closer to your speaker. There's a little bit of echo,
okay.
So we can't hear you clearly.
Is it better now?
Yeah, a lot better. Thank you very much.
Can you hear me now?
Very clear. It's much better.
Okay.
Thank you.
Sorry about that. So you can have problems of storage or voiding with the bladder, and these are some of the presenting symptoms, and that's why I want to share with you this afternoon. When one passes water, normally as a young person, you will be literally writing your name against the wall 5 feet away. But as you get older and one has prostate cancer, the stream becomes very weak. And not only that, it takes a while before you start passing water. And also towards the end, there'll be a lot of dribbling, whereas in the past, when you were younger, that doesn't happen. And when you go in there to pass water in a public lavatory, for example, there's a lot of hesitation, or what we call it hesitancy. And also the stream is, stops and starts. Now, this can be caused by benign enlargement of prostate as well, but prostate cancer does cause these symptoms. In terms of storage, then normally you don't have to get up at night, but with prostate cancer, you have to get up a few times at night, sometimes 2 or 3, or sometimes more. And in the daytime, one tends to pass water more frequently than one used to do. And if you see an adult wet in the bed, then it may well be as a result of prostate cancer, which has led to overflow. Occasionally, you can also see blood in the semen. So, ladies, this is your role, where if you notice your husband is having these symptoms, then you have to hold him by the hand and accompany him to see a urologist, so that he can distinguish whether this is due to benign or malignant enlargement of the prostate, which we refer to as prostate cancer. Dr. Sani has shown the picture before. I want to reiterate the importance of digital rectal examination, which we refer simply as DRE. Most of my patients in this country, UK, before I see them, they would have had an information leaflet explaining that a digital rectal examination is necessary. With the digital rectal examination, you can feel the prostate, and where the prostate is, stony hard, as we call it, then you can almost instantly say that this person may have a prostate cancer. So in order to diagnose prostate, just to sum up from what my previous speaker has said, that we have low urinary tract symptoms, and the digital rectal examination is essential. And also we talked about PSA. PSA is an antigen that's picked up through a blood test, and if you do it and it's high, then the person needs further investigations. Sani also referred to MRI and prostate biopsies. This example of an MRI scan, which you're all familiar with, the importance is that it's got a very high sensitivity and very high specificity, and therefore we should have them made available in our institutions so that we can have an idea of the prostate disease, especially the cancer, which with 1.5 Tesla machine and above, you can be able to, with some degree of accuracy, tell that there is some area that may well be cancerous. My colleague has also talked about TRUS, or transrectal ultrasound guided biopsy of prostate, which is now changing into transperineal biopsies of the prostate. I'm making you aware of this because if you happen to visit a hospital and these things are going to be done, then you will not be surprised at all. And once the biopsy is done and is read under the microscope, then we're looking at two spectrums of prostate cancer. I call it, the pussycat and the tiger. The pussycat is a disease that would most likely not kill the patient, whereas the tiger is the most dangerous one, which would kill the patient. So our job most of the time is to identify the tiger as quickly as possible and offer treatment, which I will be talking about. The treatment that for many years that we've offered for prostate cancer has been open surgery to entirely remove the prostate itself. This, of course, has got problems because you've got an open wound, and therefore you have to stay in hospital for at least 10 days to sometimes even a month. And being stationary in bed, you may have problems of blood clots in the leg, etc., etc. You can easily lose quite a lot of blood because it's a very vascular area you're dealing with, and there will be more complications. So as a result of this, obviously this open surgery has been ongoing for many years, but certainly it was popularized by Young et al. And other surgeons. And every now and again, open surgery has had a few tweaks to make things better. But what has really changed has been the advance of what we call laparoscopic surgery. In a laparoscopic surgery, the small incisions or cuts are made, and instruments and a camera put into the abdomen after it's been inflated, and then you can be able to see the inside of the abdomen very clearly and very magnified, and you can be able to carry operations. Of course, there are advantages with such laparoscopic surgery. Patients are able to go home quicker and recover quicker. They don't have to stay in bed for weeks on end, and blood loss is minimized, etc., etc. So therefore, laparoscopic surgery became popular, and also the structures can be seen because they are magnified, such as the nerve supplying the sphincters of the bladder, which Sani has referred to, and also the nerves that supply the penis, which he is also referred to in his presentation. But what has been more crucial as a refinement of this in terms of surgery is the robotic surgery, which has got even much more advantage over the laparoscopic surgery. This is a robot-assisted surgery, and the first and most popular one is the Da Vinci robot, and it's got an advantage of very minimal blood loss, ability to make watertight joining of the bladder to the urethra because the prostate is no longer there, and therefore avoiding some complications, which I will talk to shortly. This is an example. This is the robot, the Da Vinci robot. As you can see, the name is there, Da Vinci, and the patient lies on the table here, and these are the cameras and the equipment through which the abdomen will be pierced and put inside, and the person will be asleep under general anesthetic, and the surgeon will be sitting here in the console where he will be carrying out operations by means of this console here. His head is inside there looking into the picture of very magnified structures. And the nurse who is assisting him will be watching the operation on this television screen. And this is a robot, and it's very common now. In some hospitals here in the UK, they have more than one robot. They have maybe 2 or even 3, and a lot of operations are now increasingly done by the use of the robot because of its advantages. As you can see, that's the console. You can see the surgeon. He's using his hands here and his feet as well, as if he's driving a car, literally, but no steering, using both feet. And this is the patient, and these are the equipments that have been put inside the abdomen after it's been inflamed, inflated with gas. And the nurse is watching the operation. This is one of the equipment, and she's busy watching the operation so that if there are any things that need to be done, she's always aware of what's going on, and she can immediately offer assistance. Now, this is what you see inside the abdomen. This is the equipment that's been put inside. You can see even from this small picture, you can see the blood vessels very clearly. There's red lines of blood vessels, and therefore this is heavily magnified, and you can see even the nerves supplying the blood, the prostate, the nerves supplying the penis and the sphincters. They are like electric wires passing by, and therefore you are very careful about them. You safeguard them so that loss of these nerves may result in incontinence of urine or loss of erection. This is how the surgeon's hands fit into the console here, and he's actively, controlling the operation with his 2 hands and also his 2 feet. And this is how the robot is being utilized. Now, there are advantages of the robot, as I've said. The one and most important one is that you will have a full cancer control, meaning that you are able to remove the prostate cancer in total, and that will obviously is what the patient wishes and wants. And as I've said, the nerves that supply the sphincter of the bladder, which controls the ability to control continence, are visible with the help of the robot magnification, and therefore the complications that may occur as a result of such operations, such as incontinence of urine, are minimized. As a matter of fact, the one reason why the robot came into being was that in America, they were operating on patients with open surgery, and they created about 1 million patients who were wearing pampers like children because of incontinence urine. And so they put the heads together, and this came into being, initially laparoscopic, and this was redefined, and we have now got the Da Vinci robot. As I also said, the issue of erectile dysfunction or failure to have erection after prostate removal can occur as a result of damage to the nerves that supply the penis. So as a surgeon, we have to look after the patients very well, both before operation, during operation, and after operation. And this we do nowadays with all technology that's available to us, and the outcome is not much better than what we used to do. So to recall, I've told you that prostate cancer, you've heard earlier that it can run in families, and that if you have weak stream, or you're going very frequently to pass urine, or you accidentally wet the bed every now and again, then it is time for you to visit a urologist. And don't forget, if you wake up 3-4 times at night and you're sharing bed with your wife, then she would also be awakened by you going to the toilet and coming back. So the sharing of burden is also on the women, and therefore I'm now appealing to the women folk to please remember this, and accompany the husband to see the doctor, the urologist, so that if they have prostate cancer, then it can be diagnosed early and treated early, and the outcome is much better than late presentation. Of course, we mentioned about MRI, which is very helpful, and we also mentioned about PSA and prostate biopsies. The combination of all these will lead us to early diagnosis of prostate cancer. And at the moment, it's extremely common in the Western world to operate using the robot to remove the prostate, and what we refer to as radical prostatectomy. This has got a better outcome and very minimal complications compared to open surgery. And the idea is that Vice Chancellor, if such technology could also come across to us in Nigeria and where else but Zaria, to be able to provide this to our people. And of course, if the cancer cannot be operated, then we have other ways of treating it, and that is where Dr. Falalu comes in, and I'll hand over to him now. Thank you.
Thank you so much, Dr. Gana. Unfortunately, we lost some of the messages because of the audio, but we got a lot of it. Thank you very much. We now go to move swiftly to Dr. Danwata. Non-surgical treatment options.
Thank you very much for the invitation, for the alumni that set up this. I hope what we are going to discuss is going to help in improving the awareness of prostate cancer among men, particularly the Black population that we're talking about. As was acknowledged by the previous speakers, there are certain aspects of the presentation which has already been discussed, but because of the relevance in relation to treatment decisions, there are some bit of repetition. Regarding risk among Black, particularly in relation to lifetime risk, based on statistical assessment, some of you will be aware, for example, in the UK, there is what you call the prostate cancer audit, where all patients who have been treated for significant prostate cancer in the secondary care or specialist centers, an audit is usually done to look at what has gone well. So based on this audit from 2008 to 2010, the analysis by ethnic groups has shown that the risk, lifetime risk of diagnosis of cancer, prostate cancer, is 1 in 4 among Black, and 1 in 12 will die from the cancer. So this buttresses the significance of what we are talking about. The in relation to the anatomy, particularly in relation to my own aspect of treatment, the relative position of the back passage in relation to the prostate itself is of significance. And also in this blown up image, you can see this is the internal sphincter of the bladder and the external sphincter, which is the internal is above the prostate and the external is below the prostate. So as Dr. Gana mentioned, when prostatectomy is done, sometimes the control of the water hose can be an issue, or also if a patient presents late, that can be an issue. So in the process of prostate cancer diagnosis, I put these steps, which were already mentioned by both Dr. Sani, Aminu, and Dr. Gana, indicating that some patients will present with symptoms. Some are identified through blood test. And usually when they present to the urologist, they end up having digital rectal examination to feel the prostate. And for those that have had the test as part of the diagnosis, we end up doing a multiparametric MRI, which helps to show the abnormal beat of the prostate. When the urologists come to do the biopsy, they can go for a targeted treatment, the targeted biopsy. There are lots of studies that shows that the targeted biopsy based on the MRI scan has improved the accuracy of getting the diagnostic specimen that the pathologist can then analyze and then give us the parameters that we usually need to make a decision regarding treatment. Obviously, based on the blood test, the findings of the scan and the biopsy, we will then decide if a patient needs other additional scans in order to help to determine the extent of the problem. In assessing the extent of the problem within the prostate, we have a way of identifying if it is localized, where it is located within the prostate, and whether it is involving the capsule. This is the capsule of the prostate. If the cancer is confined within the gland, then that is when an operation is appropriate, in the sense that resection of the prostate without leaving anything behind. But if it is involving the capsule, or as in this example, if it is eating into the prostate and the rectum, then usually an operation will not be appropriate, because if the surgeon operates, they are likely to cut through the cancer and they will leave something behind. So in process of making the decision regarding treatment, we use the pathology details, the PSA, the clinical and radiological staging to stratify patients into risk groups. If a patient has localized disease, we classify them into low risk, intermediate risk, or high risk. In patients which cancer has gone out of the prostate and has gone somewhere else and affect other parts of the body, those groups are referred to as metastatic disease. So patients who have localized disease, when we offer them treatment, we are aiming for curative intent. Whereas if a patient presents with disease that has gone to other parts of the body, otherwise referred to as metastatic disease, then in that case, it's just doing treatment to control the disease burden. These are diagrammatic example of where the prostate cancer can go to. If it has escaped and has become metastatic, it can go to the lymph nodes, which are the glands that may be in the pelvis or further away. Here, they use the green example to show just normal nodes, whereas these blue ones are those where the cancer has gone to. If the cancer has gone to the bone, because in metastatic prostate cancer, one of the areas it commonly goes to is the bone. And that is why some patients, if at presentation they are complaining of bone pains, we worry about the risk of the cancer having gone out of the prostate. Now, in cancer treatment, particularly this example in prostate cancer treatment, it is a multidisciplinary approach. We usually have a team where, as we have seen from the biopsy, from the imaging, from the pathology analysis. So usually the team, the specialist multidisciplinary team tend to include radiation oncologist, medical oncologist, the GP from or the primary care representation, the urologist, radiologist. In some cases, we look at occupational therapy in patients who you want to help them to sort of rehabilitate after their treatment. We've talked about genetic assessment in patients where there is evidence that they have some genetic involvement. And obviously in patients who are not curative, we tend to involve palliative care and obviously the nursing support as well. And in developed economies where the healthcare is developed, that we do have social workers that helps with patients overall. I put this, what we refer to as disease state model. Naturally, when a patient presents, we want to have the optimistic view that they will be cured. But unfortunately, when a patient presents with localized disease, after the treatment, they still need to be followed up, because with time, you want to make sure that they do not develop further problems from their prostate cancer, because the prostate cancer can recur. So in the same patient, when you treat them, you follow them through with time, because if they develop recurrence, then you have to treat their recurrence. So these are potential different stages that patient can progress to. So if a patient typically have curative treatment, the minimum period of follow-up is at least 5 years. So in some cases, it may be longer, because if they develop any recurrence, then you have to treat them subsequently. So for patients with localized disease, Dr. Gana has talked about the radical prostatectomy. The other treatments that we do for clinically significant disease is external beam radiotherapy or brachytherapy. Sorry, I hope you can hear me quite well. Hello?
Yeah, we can hear you very clearly.
Oh, okay. Now, the patients who have intermediate risk, they have also the option of either external beam radiotherapy or brachytherapy or surgery. The selection depends on patient symptom. For example, we talk about patients with benign prostatic hypertrophy. You can have patients with benign prostatic hypertrophy and cancer as well. So if they have outflow problems, especially if they have what you call transurethral resection of the prostate, where the urethra is open so that they can pass water well, then they cannot have brachytherapy. They end up having external beam radiotherapy or surgery, that is in the localized disease stage. Now, in external beam radiotherapy, it is use of high energy X-rays to deliver a curative doses of radiotherapy to the prostate. In this diagram, you can see the prostate is lying between the bladder to the frontier and the back passage, the rectum at the back. So the hope is to give radiotherapy to the area of the prostate to high dose while trying to avoid the rectum, so and the bladder. So that is why, if you can see, this is an actual treatment plan for a patient that was treated with radiotherapy. We give a high dose of radiotherapy to the prostate and minimize the dose to the rectum. This is a picture of a modern radiation machine with linear accelerator. This head is the head that generates the X-ray and deliver it. This is the couch where the patient will lie down. This couch can go up and down, and this machine can go around the body of the patient and deliver the treatment. As you can see, these lines are lines of beams that we deliver based on the plan. So using computer imaging, you can see this is a diagrammatic representation of the beam of radiation that is generated, and these slices, they are slices of lead, and using computer technology you can shape the beam, you can shape the beam of the radiation to fit the shape of the prostate. And in the gantry, or this head, what you see is that small hole through which the beam comes out. And depending on the shape of the prostate, these leads of lead can be made to fit the shape of the prostate, and we deliver the treatment to the prostate. For patients who have brachytherapy, which is the internal treatment that is delivered directly to the prostate, this is what we call low dose rate brachytherapy. And this uses small seeds of radiation, usually seeds, which can be implanted into the prostate. The urologists are aware when this is the sort of ultrasound probe that you put into the back passage, and then you have a template through which you map out the prostate, and then you position the seeds into the prostate. So this is permanent radiation. If you put in the seeds, you leave it in the person. So the seeds irradiate the prostate, kill off the cancer, but they have to stay, they cannot be removed. So this type of radiation is done in localized disease, particularly in patients who have either low risk or intermediate risk disease. There are obviously caveats to this. Any patient that's had this kind of treatment cannot be cremated, because the current government guideline indicates that a patient with radiation seeds in them, they can only be buried when they die. So when you are having discussion with the patient about decisions to treat them with brachytherapy, you have to look at things like that. Then this one is what you call high dose rate brachytherapy. We put some needles with the applicator. This is the remote afterload, which can then be controlled remotely, and the seed of the radiation will go in and spend a bit of time, and then you retract them back. So in this one, it's not a permanent seed. You deliver the radiotherapy into the prostate, and the patient can go home afterwards without leaving the seeds behind. So for patients with high-risk disease, we give them hormonal treatment before their radiotherapy. The use of the hormonal treatment, because we think the driver for prostate cancer is testosterone. So use of testosterone, is anything that will suppress the testosterone is going to reduce the burden of the disease, and it can help to shrink the prostate. And then after giving them the hormone treatment, we give the external beam radiotherapy. And then in some cases, if they are quite high risk disease, we give them some more hormones for up to 2 years. If a patient has a local treatment, either surgery or radiotherapy, and you're keeping an eye on them and they end up developing recurrence, then you have to look at their parameters of relapse, and we scan them to check where the location of the recurrence is. And also we discuss patients' wishes regarding treatment timing for their recurrence. If they have had previous radiotherapy, then you look at other methods of local treatments. If they have had previous surgery, then we irradiate the prostatic bed. Patients who present with metastatic disease, their treatment is predominantly systemic treatment. And using the systemic treatment will normally include hormonal treatment, and various other forms of treatment. These are a list of sort of treatments that we use. There are some patients, if they have had a recurrence, they end up with what you call non-metastatic gastric prostate cancer. So in that case, we give them hormonal treatment along with other additional anti-androgens. In patients who have metastatic disease, we have various use of chemotherapy in the setting. If a patient has metastatic disease, which is predominantly in the bones only, we give them hormonal treatment along with another form of radiation treatment, which targets the bone. Radium is a substrate which is similar to calcium, and the radium is labeled with the radium is labeled with this radioactive product, which is linked, and when you give it as an infusion, it goes to the bone. So patients are treated, but in this category of patients, you are trying to control their disease burden and relieve their symptoms. When patient has had more than 2 lines of treatment, then subsequently that is when we start to look at certain genetic markers, because there are also some newer drugs that have been developed for patients with specific genetic markers. Some of you also may be aware of some form of immunotherapies which can be used in metastatic castrate-resistant prostate cancer. All these treatments, unfortunately, they do have side effects. So during the course of discussion, we have to point out the side effects of the treatment. So we always try to balance benefit versus side effects of treatment. For the radiation, as we pointed out in relation to urine function, ability to continue to have a sexual life, there is a risk of erectile dysfunction. Some patients may end up with some bleeding from their back passage. So all these are side effects that are usually discussed prior to treatment, and during the course of follow-up, we review, and where there are opportunities to give them something for their side effects, we do that. Obviously, looking into the future, as you can see from as far back as 1940, when various other forms of treatment, including orchidectomy, which removes the testes, which is the source of the testosterone, a lot of the current drugs have been developed over time. Now, the areas that are being looked at include something called a stereotactic body radiotherapy, which is essentially focusing the radiotherapy specifically to small nodules so that you don't have to irradiate the whole prostate. So this focal therapy is part of the current research going on. Genetic profiling also is ongoing because some of the target genes are being identified more and more. So I hope during the course of discussion we've been able to go through the learning points that and we can take questions as part of the discussion. Hopefully, if there are other areas that we need to shine some more light on. Thank you.
Dr. Danwata, I think it's for us to thank you. Thank you so much.
Yes.
I think we will now have a brief session for question and answer. We already have a few questions on the chat, but the floor is open for questions, ladies and gentlemen. Okay, I might start with one of the chats, the question on the chat.
Oh, yes, go ahead. Yes.
Okay, well, feel free if you want to, if you have a question before then. There is a question from, I think it's from Dr. Hassan.
Yeah.
Yeah, I think he's a.
That's right. Yes, I've got a question.
Yep.
Yeah. Well, thank you very much, the 3 eloquent speakers for a very educating session. I learned quite a lot from what you've said. There's 1 or 2 questions. You, Dr. Sani Aminu, you talk about new genes that have been discovered, which people with family history may have. Now, is there any clinical role for genetic screening of people that have high risk? That's question number one. Question number two, we know that, say, in breast cancer, women that have BRCA gene are offered prophylactic mastectomy. Is there any role for prophylactic treatment in high-risk patients of prostate cancer?
Okay, so among the genes that are found, there are ancestry, Black ancestry specific genes that were found. There was one study called the Genomic Wide Association Study. They found that there are some people, they did studies in Benin tribe in Nigeria, Bamileke in Cameroon, and they found that there's a specific region, there's a specific locus in the gene, in chromosome number 8q, whereby if there's abnormality in that gene, then you find that 88% of Africans that have prostate cancer have abnormality in that gene. But that is just showing that an abnormality. You know, it's not saying that it is it confers maybe an aggressive genes, an aggressive prostate cancer. Then there are those that are African specific, African ancestry specific genes that confers abnormal or aggressive prostate cancer. So these are two things different. I think the most important, the first one is just epidemiological, because they did it they repeated it in Sierra Leone. Then some did the study in Tobago and Martinique, Guadeloupe, all the Caribbean countries, Jamaica and America. They found it's just a proof that genetics plays a very important role in the prostate cancer in Blacks, because all those Blacks from mainland West Africa and those in Caribbeans who have gone there through slave trade, and those in, let's say, the UK, who also similarly, and also more recent comers from like us, have those genes together. So this is just for epidemiology, but the ones for that confers aggressive cancer is very important for us to know and to work on it and to do more research, so that people can know from the beginning whether they need to be monitored more closer than others, or they need treatment, not active surveillance. I think that's the importance. Then on the BRCA2 gene, yeah, I think for prostate cancer, because though it presence of BRCA2 confers an aggressive potential for an aggressive prostate cancer, I think it's just better to follow the normal protocol, yes, which means that maybe that person is not suitable for active surveillance if he develops prostate cancer. But prophylactic prostatectomy, I don't think is accepted.
Yes, if I may add, regarding the genetic profiling in prostate cancer for treatment decision, at this stage, we use it essentially in third-line option in patients who have metastatic disease. First-line options and the earlier treatments, there are more effective treatments which are beneficial. So the use of BRCA mutation to guide treatment, there is a drug called olaparib, but its significance is as I said, third-line option. Regarding prophylactic surgery, certainly we are not there yet.
Okay, just to add again, Falalu, but in diagnostics, sometimes you have a situation whereby a person maybe has, let's say, Gleason 3+4 or Gleason 6, Black yes, person, young person.
No, I agree. I agree with what you said. No.
So there's this select, there are some liquid biopsy tests like the select DX, oncocyte, DX. These ones are important in helping a person to make a decision from the beginning on whether to go for treatment or not, and also to choose between active surveillance and not active surveillance, and even the type of treatment.
Yes, obviously Black patients tend to present relatively younger age compared to Caucasians, and treatment decisions are usually more towards actual active treatment rather than surveillance, because certainly the relative aggressiveness of prostate cancer in Blacks is higher compared to other racial groups. So purely because of the presentation with high PSA, high Gleason scoring, aggressive features, treatment tend to be favored compared to active surveillance or monitoring.
Okay, thank you very much. Just my second one is more of a comment. That is, as a primary physician myself, I think one of the most important things which we need to emphasize back up in Nigeria is that primary care physicians tend to develop close relation with their patient, and you need the primary care physician themselves to be enlightened, so that not everybody having symptom of UTI in a month that just need antibiotics and go away. They also need to educate people based on their family history on when screening should start. Because while we need to get the public to understand the importance and also to break the taboo about rectal examination, they need to go to clinicians who know when it is early time to do relevant investigation, examination.
Okay, I think because of time factor, we have two questions, one from Dr. Meteboela and another question from a gentleman recognized as Solomon iPhone. So, Mr. Solomon? Okay, is Hannah Meshebela ready?
Okay, I thought Solomon was ahead of me, so
yeah,
sorry. I may have,
ready yet.
Okay, I may have missed this bit, but I think the last speaker partially answered my question. I just wanted to find out what is the situation in Nigeria in terms of, prostate cancer screening. In terms, what is the situation, and also what is our level of how far can we go in terms of therapy in Nigeria?
Okay, I will start. I don't know whether Baba Gana and Sani will add something. I'm a clinical oncologist, so I do radiation treatment and chemotherapy. In communication with colleagues back on the ground, as it was initially mentioned, the number of radiotherapy centers in Nigeria, honestly, we need more based on population. And also, radiotherapy facility is energy intensive as well as technology intensive. So our in-house engineers that will maintain these machines, some of the problem we have with Nigerian system is sometimes the machine will be purchased, but the maintenance contract is usually not something that is followed. So you can have an equipment that is there when you want to use it and it breaks down, then there is difficulty of maintaining treatment. There are occasions where patient plan is done, say in Zaria. If it breaks down, then patients have to travel to Abuja to have their treatment. So there are lots of systemic issues that I think we need to pay attention to, and it requires discipline and a sense of purpose, honestly. Medical care, as you will know, is not just limited to the doctors. You can have excellent doctors on the ground, but their ability to deliver care has to be facilitated by people that are responsible for providing the equipment and running the administrative aspects. If you have, as you can see from the presentation we made, you need a good team, because just the doctor alone may not be able to deliver an excellent care. Also, if we look at ability to pay for these treatments, there are some charities coming up, but these charities, as you know, in Nigerian setting, their ability to help the people can be limited. I think the NHIS, hopefully, if it is functional and the population coverage is going to be high, hopefully they will be able to facilitate patients' care. So there are lots of issues that we truly need to address. Some people that are well off, they go out and have their treatment abroad. But the bulk of people back at home, there are issues. These drugs in the metastatic setting, they are expensive. So within NHS, enzalutamide monthly cost is about £3,000. So you can see, without government input and subsidizing, and also if you have a large population, the government can make deals with the drug companies to be able to purchase in bulk. So there are need for a significant, Nigeria does have a cancer control program, though it's difficult for me to say how realistically implemented it is. So screening is only relevant if you are able to deal with the sporadic cases. In my view, if you do screening without the resources to treat, then you are unearthing like a can of worms that you cannot deal with. So the awareness is important, but as far as the management of the cases, we have to be careful with screening. We need to deal with what is on the ground before we can then aspire to do proper screening and cover everyone.
I don't know whether Mr. Solomon is about.
Yes, I'm still around. If you can hear me.
Please, my apology. Please, can you go ahead with your question?
Thank you very much for the presentation. We know the management in Nigeria is predominantly, either because of the late presentation, end up being either orchidectomy or possibly hormonal treatment. Because if, from what you've said, I think only very few, and indeed very, very few, can be able to afford £1,000 a month for treatment. My question is, for how long can you carry on with the hormonal management, such as Zoladex?
Well, Zoladex is a treatment that essentially induces castration level. So in an economy where there is issue of drug access, orchidectomy honestly is a realistic option, because when you do the orchidectomy, you are removing the source of the testosterone. So you will, I mean, in the Europe, they used to do orchidectomy before the drug manufacturers, because ongoing Zoladex is also not cheap if a patient is going to have it for a lifetime. So orchidectomy is still an option in places like Nigeria. Obviously, the acceptance, you know, sometimes the problem with our people is the acceptance. Someone will have a clear diagnosis of prostate, but he will be worried about his masculinity and will be worried about issues regarding erection and things like that. So obviously you have to pay attention to patient wishes, but on the other hand, as a doctor, you have to be frank with the patient and tell him is either to have quality of life without the life, or preserve the life and manage with what is there. And if the family, because as Dr. Gana mentioned, when a cancer affects a patient, it's affecting the whole family. So
Yes.
the wife needs to come along with the patient and listen, and then hopefully if they are at a relatively old age, they will be supportive of each other and look after each other as best as possible.
So can I just make a quick comment?
Thank you.
This quick comment I wanted to make this. When you say the option is between either having their sex life or having their life, and they don't have both by castration and giving them Viagra.
In patients who have erectile dysfunction issues,
Yeah.
they are managed through the in our hospital here. We have erectile dysfunction clinic for patients who have undergone prostate cancer treatment and are having erection issues. So yes, there are measures apart from something like Viagra. There are other mechanical things that can help with the actual so the quality of life is something that is looked at as part of management of post-treatment toxicity.
Thank you.
Thank you.
Excuse me,
I come in here.
we have some urologists from Nigeria. I think Dr. Kura and Dr. Mohammed, they could tell us they can say a word a bit about the challenges and what they do there.
Can I also add into following what Dr. Falalu said regarding orchidectomy? I have practiced in this country orchidectomy, and I used to do it as a day case procedure, at least 2 operation lists per week, until the advent of Zoladex came in, and there was a concerted campaign so that Zoladex can be kind of acceptable to patients instead of going through orchidectomy. I think it is still, you can do it, you can practice it, and as we said earlier on, the care of patients with prostate cancer is a teamwork, and one area is penile rehabilitation for those who have problems of erections. We have a team that can look after them and treat them, and we can tailor-make some of the treatment towards the patient. But by and large, you know, it's a very big teamwork, and we have to make use of all the resources available. Just to add to what Falalu said.
Well, thank you very much, ladies and gentlemen. I think we're running a little bit short of time. This certainly is a very important subject, and with which we have more time. But unfortunately, we are about 10 minutes ahead, behind. Well, please, we can have a look at some of the questions on the chat, and if possible, maybe the speakers can offer answers that we can have on our website. We consider that as an option. I will quickly call on Dr. Sani Aminu to give us a brief summary of take-home messages.
Okay. Can you see my slide?
Yep.
Yeah, yes, we can.
Okay. Thank you very much, fellow alumni and attendees, for this session, for this program. And I shall just run through the take-home message. First of all, prostate cancer, as we have discussed, is the commonest cancer in Black African men, especially those of West African ancestry that are in Nigeria, West Africa, Caribbean, Europe, and North Americas. The lifetime risk, as Falalu has shown, is 1 in 4 in Black Africans versus 1 in 8 among whites. In Blacks, they have earlier onset, unfavorable biology, and higher mortality. West African ancestry-specific prostate cancer gene abnormalities were found, as well as those that confer poor outcomes on bearers. targeted screening of Black Africans for prostate cancer from the age of 45 years was recommended from studies in Europe. And this includes PSA test, digital rectal examination, and if necessary, to go ahead with MRI also. Spatial scans and genomic studies have improved precision in diagnosis, treatment, and they have helped us a lot, surgeons and oncologists, to prevent overdiagnosis and overtreatment. In Nigeria, health education, reorganization of cancer services, and research are needed to find the best screening protocols, guidelines, and pathways. But well-informed individuals do not need to wait. They could go ahead with their screening and treatment. We have also discussed, my co-speakers have kindly told us about the treatment modalities, including both operative treatment and non-operative treatments. For prostate cancer within the prostate, both operation and radiotherapy give effective cure. For prostate cancer that has grown up to the age of the prostate, what we call locally advanced, radiotherapy, hormonal therapy, and chemotherapy are the modalities of choice. When we have widespread prostate cancer, or what we call metastatic advanced prostate cancer, the aim of treatment is palliation with the above, like radiotherapy, hormonal therapy, and chemotherapy, minus curative operation. If any operation is done, then is to control symptoms. Minimal access operations, as discussed by my co-speaker, mentor, Dr. Gana, like robotic, is quite less invasive. There's minimal blood loss, early discharge home, and early return to work. This is of great advantage. Additionally, the good vision and magnification with the robot helps in precision in the anastomosis, or the joining after removal of the prostate, the joining between the bladder, neck, and the water pipe, the urethra. Importantly, it is much easier to see the nerves, the erectogenic nerves, to protect them very well, hoping that erection will be preserved. Newer focal ablative therapies are being offered these days using energies like ultrasound scan, which there's one we call high intensity focal ultrasound. There's also cryotherapy. They are evolving, but are available mainly under clinical trials. They are done a lot in Europe and North America, but mainly under clinical trials. Newer drugs, immunotherapy and genes-based therapy have great potentials. In summary, right intervention with minimal complications for the right patient at an acceptable cost is needed. And screening is also an intervention. So as Dr. Falalu mentioned, it has to be done in a proper context. Otherwise, it will lead to harm. Because if you screen a lot of patients and there's no capacity to treat them, then you have put harm on them, which is psychological burden. So that's why research is needed, so that we establish guidelines and pathways needed to plan. Thank you very much.
Thank you so much, Dr. Sani Aminu, and thank you all the speakers. A very special thank you to everyone for joining us. Apology, we're running short of time. We still have the Vice Chancellor waiting to speak, and the National President as well. So apology that we're rushing. But just before we go, I just want to express a big thank you to the speakers. There is a quote from Maya Angelou, the American poet. I think the quote says that if you learn, teach. If you get, give. I think our speakers have demonstrated very clearly today, by giving us their time, their ability to teach, and their ability to give. We're grateful to you all for all you do in the interest of public good and for all you do in the unique spirit of giving back. I will now call upon the Vice Chancellor, Professor Kabiru Bala. Apology that we're running late, Vice Chancellor.
Thank you very much. First, let me sincerely apologize. I couldn't join the meeting earlier than now. There is this annual lecture, the Area House annual lecture. We were engaged there. I thought we'd finish in good time to start this meeting, but it lasted long. So I'm sincerely sorry. I just joined about a few minutes ago. I would perhaps have a request for a recorded version of the meeting so that I can listen to it in due course. However, in ABU, we send our greetings and we are sincerely appreciative of this effort you are making. And I hope we'll derive the maximum benefits from that. We're also trying, I should say, to see if we can give a new direction to the university, principally aimed at attaining excellence in whatever we do, in all aspects and ramifications. And with the also central goal of making ABU sustainable in the long run. So what we are trying to do is to see if we can actually develop, we are actually in the process of developing a long-term plan from which we will have short-term and medium-term plans for the university also. So in various aspects of the university's business. In Faculty of Medicine, for instance, we have a plan, Faculty of Engineering and other faculties. And I think maybe in due course, because we have run short of time, I think we are running short of time. Maybe I'll have, at another occasion, I'll try to give details of what we are doing to see where you people can come in. I think you can do a lot in trying to help us, help the university to direct all efforts towards attaining excellence and then sustainability. We must think of having a university that will be sustainable going forward. Once more, thank you very much for the invitation. Thank you very much. Keep up the good work you are doing.
Thank you so much, Vice Chancellor, Professor Kabiru Bala. I will be cheeky and I will ask the chairman to respond very briefly. Dr. Ibrahim Hassan, do you want to respond? Okay.
I think he's muted.
Oh, he's muted. Okay. Okay, then. I think we can move on to the next speaker. Then.
Oh, okay. I'm muted now.
Oh, okay. I was wondering whether you want to respond to the Vice Chancellor.
Okay. Thank you very much, Professor Kabiru Bala. I know you are a very busy man, and I can see from what you say how much what effort you put into be able to come to speak to us today. And we're looking forward to listen to the more detail so that we'll see how we can come in, how we can help. Thank you very much for your time. We're very appreciative. Thank you.
Welcome. I'm most welcome.
Thank you very much again, the Vice Chancellor, and thank you, Dr. Ibrahim Hassan. We also privileged to have the President, ABUAlumni Worldwide, Architect Sani. We'll be grateful if he's able to speak to us. Okay, if the President is able to join us later, then we can, we will listen to him. But we'll move now to the closing address by Dr. Ibrahim Tinau. Sorry to put you ahead of the president, but if the president comes thereafter, then we will listen to him.
Thank you very much, Dr. Joseph. It's not really an address, it's basically a vote of thanks and closing remarks on behalf of the Association of UK and Ireland. First and foremost, I would like to thank Dr. Sani, Gana, and Falalu for a very informative session. And actually, I think this was simply brilliant. And I think we should continue to have more of these sessions from our own association. Dr. Sani has already made an excellent summary of today's session. And I think the most important thing to go home with is that to combat prostatic cancer, it's very, very important to detect it early. Early detection, when it's confined to the gland, has the best chance of successful treatment. And we've learned that health education, and Sani has also mentioned the need for screening is so important in this aspect of treatment of prostatic cancer. And we've also learned that in the treatment of prostatic cancer, it's a multi-modality treatment, and it's also multidisciplinary. And but the most encouraging thing is that with modern treatment and technology, there's hope in the sense that there's a definite advancement in the treatment of this prostatic cancer. I would also like to appreciate and to say that we're highly honored with the presence of our distinguished Vice Chancellor of Ahmadu Bello University's area, Professor Kabir Bala, and hopefully later on the president of our ABUAlumni Association worldwide, Architect Ibrahim Sani Khalil. Reading his inaugural speech last January, Architect Sani Khalil did mention that the art of giving back shall be his guiding principle. And I think we should not underestimate the power of that. That is very, very important. And as Winston Churchill once said, we make a living by what we get, and we make a life by what we give. At this juncture, I would like to call on all graduates of Ahmadu Bello University's area, residents in the UK and Ireland, to please join us and make our alma mater a great place. You can join using, we're online, so you can join us using our website, or you can contact any of us and we'll get you in. Finally, I would like to say that I have to thank my colleagues in the Alumni Association UK and Ireland, the ESCO, for a great job well done. It's been an honor to be among such accomplished individuals. This was really well attended. And I think I would like to thank all our attendees for your patience. And I wish you all a very good evening. Thank you.
Well, thank you so much. We actually have an unusual opportunity now where we have a bit of time after the closing address. We have about 10 minutes to spare, which was at the time allocated to the president. I don't think the president is able to join us. We have the option of taking a few more questions, especially questions on the chat or people who might want to comment. If we don't have any further comments.
Joseph, this is Falalu. I honestly want to use this opportunity to thank Professor Kabir Bala for getting to attend to us. And one of the reasons why we truly want him to join is to have the opportunity to look at the plan, because through another forum, I had the opportunity to hear some bit of what the university is thinking in relation to the role of the alumni. And I think those of us in diaspora, as Ibrahim Tuna and the President Dr. Ibrahim Hassan mentioned, we do need to invite as many people to join hand and truly do whatever we can to help to make ABU as great as it can be. We have gained from it. We need to leave legacy for those to come. And it is something that we should be proud of. And I sincerely hope we will, when we make the provision, we'll give Professor Kabir Bala a good time to, so that we can have the presentation and see how we link up our activity, because if there's a plan on the ground, if everyone is working towards achieving that goal, then we have higher chance of success than doing isolated projects here and there. So that is what I want to say. Thank you.
Can I just
So much for that.
can I just add this? I agree 100% with what Falalu said, and in fact, I'm not. It's not confirmed, but we're going to discuss having AGM sometime around June, July, and once we agree on that, I will give him adequate notice so that he comes to speak. Because, like he said, he talked about different faculties, what plan he has, which is very important to hear from him. So yeah, 100% agree, and I assure you, will continue the lesson. I mean, obviously, you are the lesson person through whom we get the content, so that will be continued. And if there are no questions, I just wanted to talk about 2 or 3 membership issues. Brian Tina has already invited member, which is very important. And secondly, those who are already members, please remember your annual dues, because the reason why we have not pushed it before now is we're a bit quiet, not doing much, but now we're getting more active doing things and we need money. So please, those who haven't paid, you need your annual dues paid. And then the other thing I also want to say to the members, our WhatsApp platform is not the only platform we have. In fact, we are now putting more emphasis on our website, but both are going to be left. The important thing is, please, I did post the aims and objectives of our association about 2 months ago, just to remind people, all posting on the website have to be compliant with an aim or objective of the association. I mean, it's not a partisan political platform. It's not a quarrelsome platform. It's a platform that we exchange ideas, we educate, entertain, and inform ourselves. And everything will, all the entertainment, education, and information should be compliant with our aims and objectives. And because we are already losing members who have been rightly put up by the quality of some of the articles that have been posted, we just feel we have no option, but we have to be very robust in making sure any article that are posted that do not comply with our aims and objectives will be taken over. And if problem persists, it might be lesser of the 2 evils. And the 2 evils are, do we allow 1 or 2 people to just drive all the members away, or we do it as the member who cannot comply may have to be taken on the platform. We don't want to do that because we are an inclusive association. We want to bring people together. So please let us use our platform more appropriately. And please, for those who are members, do pay your membership dues. And also, for those who have not visited our website, please do visit it. It's a lot of information for all to use. Thank you very much.
Just a quick question, sir.
Yep. Please go on, Dr. Felix Akade.
Okay. Right. Apology for joining the meeting a bit late, but I'm just concerned about the availability of, because from the pharmacist point of view, I'm just trying to find out the availability of the of medications in Nigeria or in Africa in general, because like we said, some of the options that have been mentioned there, which are available on the NHS, not a lot of people can afford it, especially in an environment where there's no definite plan for the, I mean, we cannot see the definite plan even for the basic health care, talk less of specific situations like this. So I just don't want to know how the medication situation could be better handled at home. Thank you.
This is Falalu. I mentioned previously, because as you will be aware, every year there's a National Cancer Day. So in the last National Cancer Day, we had a program in conjunction with the BBC, and we had participants from Nigeria. Everything is in, there is hope, honestly, because there are voluntary organizations that are now joining hands with some manufacturers, and they are getting some of the drugs at a subsidized price from the manufacturers and selling onto the patients, and it is truly a non-profit setting. I am aware, obviously the problem is the volume, because by Nigeria's population, certainly voluntary organizations cannot do a lot. We certainly want to hopefully with time get as much coverage through the National Health Insurance Scheme. At the moment, as you will be aware, the National Health Insurance Scheme is predominantly limited to people in employment of either the federal government or the state government. And also, by virtue of our family size, the provision currently made under the NHIS is really not fit for an African family. So I think with time, there are people working hard in trying to make it workable, but it is taking time. But I am hopeful that there will be more and more as there is more awareness, and there is more, because the problem with Nigeria is, unfortunately, you need people who are truly selfless to try to bring things together. Nigeria's resources is there, is trying to make it as because healthcare is really more social than business. So in a way, the government input and the government controls need to be there. And then the professionals, our colleagues that works in hospital, also need to look at their role, not just in making money, honestly. They need to realize their social responsibility in delivering care to our fellow citizens. Thank you.
Can I also add, although I was not one of the speakers, but in the take-home slide by Sani Aminu, there's something in that slide which is relevant to your question. And what he said in that slide, which I agree with, that is, we need local research to guide local protocol and guidelines. So the point, Dr. Akande, the point you make is very valid, and we cannot just carry what is done here and just do it in Nigeria. We need our own local research to have local policy and guidelines. And if the government buys into those local protocol and local guidelines, then that should have the problem, hopefully.
Just one more comment, sir.
Yep.
Am I allowed?
Yes, you are very much allowed.
Okay, thank you very much. As I mentioned, as I mentioned before, when you asked me to give my resume, one of the things, the others, is advocacy on health and social care. Honestly, one of the advocacy things a group of like ours need to do is to press on the government or to advocate on the government in our country to establish expert committees in the Federal Ministry of Health, expert committee on cancer, expert committee on heart diseases and stroke, expert diseases on diabetes and digestive, things like that. Then you get subcommittees on breast cancer, prostate and other urological cancer, women's cancers, and things like this, children's cancers. Then those committees then sit down, do a bit of research, and say, okay, this is what we feel is the guidelines on this. This is how you purchase drugs. If you want, or this is how you purchase equipment. Do you purchase it maybe higher purchase, or is it lease purchase, or is it purchasing upfront? Because sometimes it's the same thing that Falalu mentioned, that sometimes, you know, you don't have even, you buy equipment and there is no service plan. You get me? Equipment that are very, very expensive, but you have not, because you have not involved those experts there, maybe you have not involved an expert committee to advise you on maybe the cost effectiveness of particular equipments or medications. Then you find that those that are buying it don't have even time to maybe discuss about service plan, you know? So for example, in this country, there are hospitals where even a suction machine, they buy it on lease purchase, or they take it on hire purchase, a suction machine. So I just wish to just call on us as an organization to please do a lot of advocacy, because some advocacy, I mean, not the only way we operate, but one of our strategies needs to be advocacy, because it's very resource and cost effective way of asking those that are holding resources, please and please do this. Consider doing a committee on this. Consider doing this one, so that because you cannot run a cancer, people will not benefit from it if it's not planned very well. And to plan, you need basic research, you know, to create guidelines, pathways, and all these things. Thank you.
Thank you very much. Except we have any question, we will draw the session to a close. But we can take one more question.
Mm-hmm.
The Director of University Advancement has joined. Maybe you may want to say a word or two, please.
He's very welcome, sir.
Mm-hmm.
Hello.
Oh.
Hello, good evening, all.
Director of University Advancement.
You know, good evening,
Yes.
you know, Prof.
Yes, good evening, everyone. Yes, good evening, everyone. My name is Professor Ahmed Toko Ibrahim. I'm the director of the Directorate of University Advancement. Our relationship is to serve as the interface between the university and the alumni body. And so we coordinate all in conjunction with the Alumni Association, all engagements with the alumni fold. We are reaching out. We see the Alumni Association as a voluntary association, but then by virtue of being graduates of ABU, everyone is conferred with the right of the alumni status of the university. And so in addition to reaching out to alumni through the association, we also reach out to the alumni directly from the individual departments and faculties. And on the basis of that, of course, some time ago, there was a call. Of course, that call was a very difficult one. We have established a link on the university website where people can actually add their contact details. The details we have about each individual already is there on the portal. All we just need is your additional information so that we'll be able to keep an interactive database where people can link up with each other subsequently. If you graduated several years ago and may be wondering where some of your other colleagues may be at the moment, there are people from other different departments that you may have had encounters with in the university. We feel we should have a platform where people actually can link up with each other once again. And so we will keep it as interactive and as lively as possible, while coordinating the alumni interface professionally as possible. I'm sure the Vice Chancellor during his remarks had highlighted the interest of the university to create sustainability plan for the university. We feel our dependence on government funding, even if we do want to, the funding will not even be there in the first place. And so the university has taken a very deep look, introspective look, to begin to imagine ways of gaining some level of sustainability in running our affairs in the future. This we can't do without active consultation with the alumni body. People have had very varied experiences over time that I'm sure they can chip into our plan. And so we do have one of the plans is we have established an endowment fund already being constituted for that. Account will soon be populated so people will know about it and begin to see the plan that the Board of Trustees intend to do in creating, financial sustainability for the university going forward. In addition, the university intends to go into integrated farming. Of course, we have over 700 hectares of agricultural land with one of the widest agricultural complex, faculties of agriculture, the Institute of Agricultural Research that is been in existence for 100 years now. We do have the National Agricultural and Animal Production Research Institute. We do have the National Agricultural Extension Research Institute also, in addition to the faculties of agriculture and faculty of veterinary medicine. And so we want to go into large-scale integrated agriculture that will involve both animals, the crops, both short-term crops and even long-term economic trees. And then intending to have the entire value chain from production through processing, and packaging and sales. And so we will be showcasing those plans and sharing them with you in due course and see how you can make your contributions directly in terms of our plan and how we have conceived our ideas and also contributing towards its actualization. It's a great pleasure to be with each and every one of you this evening. And thank you very much as we look forward to engaging in the future. Thank you.
Well, thanks so much, Prof. Prof. Diko Ibrahim. We are really grateful for that useful insight. Dr. Ibrahim Hassan, I'm in a difficult position where I don't know whether you want to have an input.
I don't know if I'm muted. Can you hear me?
Yes, I can hear you.
We can.
Okay, actually, just to say thank you to Professor Ahmed Diko Ibrahim, and about whatever we can do to help is what we're all about. In fact, Article 2.3 of our Constitution says part of our aim and objective is to provide assistance to various components of the university. So whatever way we can help, it is part of our aim and objective. I was very happy to work with the university to contribute our fair share. If we can have that website detail where we can log our details so that we can put it on our website for members to see and log on their details there. So if you could please let me or put it on the screen now so that we can have it. Thank you very much.
I just posted them on the chat box.
Oh, in the chat box. Okay, that's fine. So we'll paste it on our website and our WhatsApp platform so that members can see and everybody will be encouraged to go there and register. Okay.
Thank you very much.
Thank you.
Right. Thank you so much, everyone. I think we can draw the session to a close, except there's any further comments. I just want to say a big thank you to each and every one. Thank you for taking the trouble to attend. I particularly want to single out people behind the scene, behind the scene in getting this, meeting up and running. Dr. Ibrahim Hassan, Mr. Kenny Alawasin, Dr. Shade Tolani. Thank you so much for all the work you do behind the scene. And a very big thank you again to all our speakers. Thank you for giving us your time, valuable and precious time. And thank you for your contribution to, I'm sorry to say, for your contribution to humanity. Sorry for using the big word, but that is what you do. And if one life is saved because of this lecture today, if one person is being directed to the appropriate treatment, then this lecture will have achieved the maximum aim. Thank you so much and have a great evening.
Thank you.
Thank you.
Thank you very much.
Thank you.
Thank you.
Thank you. Bye.
Thank you. Bye.
Thank you, Falalu. Thank you, Dr. Babaga. Thank you, Ibrahim Hassan.